I will now discuss the regulatory strategy for Zometa, referring mostly to the American and European markets. Zometa has been approved for the treatment of hypercalcemia of malignancy, also known as tumor-induced hypercalcemia, which means high levels of circulating calcium caused by cancer. Additionally, Zometa has been approved for treatment of complications in multiple myeloma and bone metastasis from solid tumors. In terms of dosage, Zometa is given as a 4 mg dose as a single intravenous infusion. Because Zometa is rapidly processed by the kidneys, the infusion must take place over the duration of no less than 15 minutes. This slow infusion can help to reduce the risk of renal complications. However, this is a much more rapid and easy treatment than the previous standard of care, which is permidronate, given over the course of a 2-hour infusion. So to look at the dose schedule for the different indications, so for hypercalcemia, a single infusion of 4 mg is given also over 15 minutes. In Europe, this has been approved as a single treatment, whereas the FDA in the US indicate that another 4 mg retreatment can be given after a minimum of 7 days. For treatment of multiple myeloma or bone metastasis from solid tumors, again, the dosage is 4 mg, a single infusion, no less than 15 minutes, and this is given every 3 to 4 weeks. And because of the risk of renal complications, the creatinine clearance is first examined in patients. So the 3 to 4 week regimen is given in patients with a creatinine clearance greater of 60 milliliters per minute. And the dosage is instead reduced for patients who exhibit renal impairment. And it is also specified that calcium supplements, as well as a multivitamin containing vitamin D, are also co-administered with Zometa in these patients. To point out some differences of the American FDA approval from that of the EMA in the EU, treatment of metastasis with Zometa, it is specified that it must be in conjunction with a standard anti-cancer or anti-neoplastic therapy. As we mentioned before, that Zometa is not approved as an anti-cancer treatment, rather for the treatment of cancer-related, skeletal-related events. Additionally, the FDA also specified that prostate cancer should have progressed after treatment with at least one hormonal therapy. Androgen therapy is the current standard of care for prostate therapy, and this can lead to decreased bone density and the increased risk of skeletal-related events. To now look at the different patient populations that Zometa is approved for or not. In geriatric populations, the dosage and treatments are the same as younger patients, although there is an increased risk for renal complications in these patients. And as I mentioned, kidney function is assessed and the dosage level is based upon their kidney function. Pregnancy is a contraindication for Zometa treatment, since animal studies showed a high level of reproductive toxicity of Zometa. Also, in nursing mothers, although it has not been directly shown whether Zometa is excreted or milk or not, because of the potential for very serious adverse events in nursing infants, Zometa is not recommended for nursing mothers. In pediatric use, Zometa is only recommended or approved in instances where the benefit outweighs the risk, such as off-label treatment of pediatric patients with osteogenesis imperfecta or brittle bone disease. The reasons for this is because there were a set of events or adverse reactions shown to be more common in pediatric patients than in the adult population, and also concerns due to the long-term retention of bisphosphonates in bone. In the EU, there were 2 applications to extend the application of Zometa, which were withdrawn. These were for the prevention of fracture or bone loss in postmenopausal women with early-stage breast cancer treated with aromatase inhibitors, and also as an adjuvant treatment for hormone receptor positive early breast cancer in premenopausal women for whom hormonal therapy is recommended. The applications were withdrawn due to concerns over the clinical trials and the definition of early-stage breast cancer, but also for the lack of data supporting the potential anti-tumour activity for Zometa. Additionally, bisphosphonates, including Zometa, were subject to a class review in the EU because of their association with atypical fracture of the femur. So this was first noted in patients taking the bisphosphonate alendronic acid, and it was assumed that the increased risk of femur fracture may indeed have been a class effect. However, it's important to note that the withdrawal of applications and also the class review of Zometa had no effect on the use of Zometa in its approved indications.